Hello, my name is Austin Anderson. I'm a third year ENT resident at Detroit Medical Center, and I am talking about tranexamic acid for post-tonsillectomy hemorrhage, which is a quality improvement initiative I undertook earlier this year with some of my colleagues at DMC. Some of the other contributors and our affiliations, I did this in conjunction with my ENT attending, Dr. Gonick, who's one of the pediatric ENT faculty over at Children's. And we worked with some great emergency medicine colleagues, Dr. Levasseur, the attending, and two of her fellows, Courtney Kelly and Melissa Chiappetta. We are all affiliated with Children's Hospital and Detroit Medical Center. So a little bit of background about this project and why it's important. Obstructive sleep apnea affects anywhere from 2 to 6% of the pediatric population. And it's a significant disease with significant effects. It have a lot of long-term adverse health effects, such as hypertension, cardiac arrhythmias, developmental delays, even behavioral disturbances and failure to thrive, as well as excessive daytime fatigue. What's neat about this is that the first line therapy for this is actually surgical. It's adenotonsillectomy or TNA. We do, more than 500,000 of these in the U.S. alone every year, and Children's Hospital, we do hundreds or thousands of these a year. What we do when we look at the tonsillar pillar in the operating room, we grade it from 0 to 4. So 0 being they're very small, 4 being they're almost touching in the back here. We use monopolar cautery to remove the tonsil, and we don't suture anything closed. And what you have is kind of this open scab almost in the back of the throat there. And you can see why that might lead to some issues. So the most common complication that we talk about with patients when we're recommending the surgery is actually bleeding. So anywhere from 3 to 5% of children undergoing adenotonsillectomy can experience post-op hemorrhage. National averages range anywhere from 2.6 to 10%. And the bleeding can be anything from blood-streaked sputum to brisk bleeding with associated airway instability and even possibly death. We break this down into primary hemorrhage, which is within the first 24 hours after surgery, and secondary hemorrhages, which is anything after that first 24 hours. Interesting to note that the secondary hemorrhage is roughly double the incidence, tends to happen at that 5 to 7 days post-op when the scab in the back of the throat starts to work loose and fall off. And you can have some bleeding that can, again, range from very mild bloody spit to something that's more persistent and may require intervention. So if these kids are bleeding and they're, coming to the hospital, 3 to 6% of more than 500,000 is a significant amount of children that are bleeding after the surgery and oftentimes requiring a trip to the operating room. So across the nation, some people have been giving TXA or tranexamic acid in these patients in post-tonsillectomy hemorrhage. And there's a national trend, and some of the data that's come out of it has been pretty promising. So in one study, what they did is they looked at patients and their risk of going to the operating room when they're coming in with a post-tonsillectomy hemorrhage, either primary or secondary. What they saw was that over here, the patients that didn't get TXA had a 73% chance of going to the OR, with a decrease to 29% risk after nebulized TXA. So there's a lot of confounding variables I won't get into here, but it is solid enough data that other people and other institutions and tertiary and quaternary care pediatric health systems across the country have taken notice, and some of those have started to give TXA. But there hasn't really been an excellent, randomized prospective, randomized clinical trial that has set the bar for what the protocol should be, what the dosage should be, who should get it, when they should get it, and that sort of thing. So What actually started this whole project is we had a tonsillectomy patient that had a bleed. That was another ENT attending that is at a different hospital system. And I called him the next day to let him know how his patient was doing. And he asked me, "Oh, did you give TXA?" And I said, "No, we don't really have a protocol for that here. I've heard of it, but we don't really do that here." And he said, "Well, anecdotally at our hospital system, we started giving it, and I think we've seen a decrease in rates going back to the operating room about 50%." That was significant enough for me to really perk my ears up and want to try to come up with a protocol that we could implement at our own hospital as a part of a quality improvement at Children's. So we did the PDSA approach here where we, planned together. We met and had some Zoom meetings where we sort of discussed some of the research and some of the papers, what our goals for the study or for the quality improvement initiative were going to be. We got it approved. We came up with a guideline. It has this really nice flow chart that I'll get into. And we got it approved by the medication use committee over at Children's Hospital to give this medication. So we've sort of implemented it. We gave a pre-implementation survey as a part of kind of gauging everyone's familiarity with it and how well they think it's going to work. We'll get that as well after the project's been up and running for a little while as part of another way to kind of gauge the process. And we're sort of in this do and study phase right here, where we're getting some of the data actively, but haven't really started to analyze much of the outcomes yet. So this is our protocol. You can see it's nice and broken down into a tiered system of urgent, emergent, and resuscitative management. One thing that's unique about our own protocol or our own clinical practice guideline here is that it's tiered in terms of severity of bleed, and patients may be coming in with a small clot, or maybe they had some bloody spit, and maybe it's not appropriate medically to give them this medication. Whereas on the other end of the spectrum, you might have patients coming with a brisk bleed. They're going to be getting not only nebulized TXA but also IV. So we really like this flow chart. It's broken down. It's nice and easy to understand, and it's going to be in the emergency departments for all of our colleagues down there to use it when they come in. This is the survey that we sent out. There was a survey for the ENT faculty and residents, as well as one for the PEDS EM residents and faculty, just to kind of gauge familiarity and confidence in this medication, how they feel like it's going to affect things. So in summary, post-tonsillectomy hemorrhage is a common but serious complication after tonsillectomy. TXA has been shown to be safe. It's an effective medical adjunct to the management of this complication, which is often surgical. And we proposed and implemented an institutional specific clinical practice guideline and plan to track the data prospectively to really quantify the impact of our QI intervention, hopefully save a significant amount of kids an unnecessary trip to the OR with a simple and effective medication. Thank you for your time.